Assalamu alaikum. Good evening, everybody. So we will start our second day course for COVID-19 course for non-ICU physician. This is the eighth course. Thank you to join us for this important course, actually, with this crisis, with this surgical plan to cover the health care system. So we will today we have the first lecture. We will discuss about shock and fluid management in the COVID-19. The second lecture will be essential of mechanical ventilators. The third lectures, it will be about ERDS management. The fourth lectures, it will be about pharmacological in COVID-19. So we will start with the first lecture. I will present the shock and fluid management in COVID-19. So here our learning objectives, we will discuss about fluid responsiveness, what's the definition of shocks, and what is the pathophysiology for that. In addition to that, we will discuss about the types of shocks and the clinical manifestation of shocks. We will discuss about some therapeutic modalities of shocks. So here we will discuss about fluid resuscitation, because this is very important actually to know the volume status of the patient, if he need actually fluids or not, because as we know, fluid is a drug. So it is not just something to give it and without side effect. So any drug has side effect and there is some benefit. So here we can get some side effect from that. So we have to know what is the important for this patient, what's the benefit for this patient to give him this is medication or no. So if you can, if you want to know this patient actually he need this fluid, so you have to assess the volume status before to give him the fluids, because the fluids actually the volume status they found around 52% of patients they are fluid responsiveness. So as you are flipping the coins, maybe they will get benefit, maybe they will not. So this is very important to assess the status of the patient. Because the fluid resuscitation, it's actually, it will help to increase the mean systemic pressures, which improve the venous retain. Once the venous retain improves, the diffusion of oxygen will be improved and the shock status will be better. But if you give more fluids, more resuscitation, it will help, it will make more hemodilution. At the end point, it will decrease the cardiac output and it will increase the capillary pressures, which will worsen the situation. Also, the edema, it can be progressive with making more vascular injury. So here, as you see in this slide, this is they discuss about the relation between the fluid loading and the complication, because if we give more fluids, we will be more complication. This was done about in the surgery, even in the other situation, like in the COVID-19, especially with ERDS. So if you give more fluid, it will be more mortality. But even if you underestimate or under resuscitation, you will get more mortality. So the best to be balanced. So you have to assess the fluid status, but keep in your mind, who's today fluid responsive, maybe tomorrow he will not be fluid responsive. So not the same assessment every day, it will be different from the other day. So keep in your mind, you have to keep your patient in balance, avoid hypovolemia or volume overload. So what are the consequences of generalized edema? Because as you know, if you give more fluids, you will get more gas exchange impairment. So it will be more edema, maybe more also at the end of advanced stage, you will get more CO2 retainer. But in generally, impaired oxygenation. It will cause more brain edema, can cause sometimes, and decrease level of consciousness, affecting the outcome. Also, it will help. It will increase the gut dysfunction because more gastrointestinal cells edema, which it will cause more feeding intolerance, vomiting, maybe risk of aspiration. It will be higher, maybe also gut infection, transmission of the bacteria, risk of bacteremia and fungus will be higher with them. So also increase the intra-abdominal pressure. And if the patient has wound, the wound, it will not be healed properly. Even the cardiovascular muscles, it will be affected, more dysfunction, more also like if he has RV failure because volume overload, or maybe if the patient has pressure ulcers, they can progression rapidly, and they are higher risk. Who has edema, they will be higher risk to develop the pressure sores, and even it's affecting the mobility of the patient. So it's affecting overall the outcome. So here this is a trial. They are comparing between balanced crystalloids and normal saline, which is 0.9 of sodium chloride. So if you found in this study, they found most of them, they are favor of balanced crystalloid like Ringer lactate or Hartmann fluids, except in the cardiac, which is AO balanced. And the other study, even for the brain surgery, who has surgical neurological symptoms, or maybe I mean, traumatic brain injury, they are favor of going with saline. So overall, balanced crystalloid is preferred, except in neurological, in cardiac, which is in this trial going with normal saline, and the other with a traumatic brain injury. So how we can evaluate the fluid responsiveness? So there is a lot of methods to assess the fluid responsiveness. So we have check the inferior vena cava, which is just ultrasound. You will put it in subcostal view, and you can see how is the inferior vena cava, where there is collapsing, not collapsing. The other issue, you can check the lactate level, how is raising as evidence of hypoperfusion, and you can check if they are, once you give a fluid, the lactate is improving and the blood pressure is improving or not. And there is advanced methods for patients with mechanical ventilators. So it's beyond of this course. Even the stroke volume variation, pulse pressure. If the patient has a line, just you will see how is the waves of pulse variation it will be. The other method, which is simple actually, passively grazing test, which is not harmful. Just you can check the fluid status. In addition to that, the central venous pressure. So this is the passively grazing. Just the patient, he should be initially in the sitting position, 45 degree. Then you will raise the legs, and back it will be in 0 degree. So after that, this is here, the legs, it should be not 90 degree. We will go to check how is the fluid ongoing. So if you keep the legs more 90 degree, it will be more problematic, and because the blood will not come back. So you have to keep this vein open with this situation. So the blood, once you put the patient in this position, the blood coming from the legs as around the 300 to 500 ml going to the heart. So if the patient fluid responsiveness, you will find the blood pressure is improving. But once you put the patient back to the initial position, you will find the blood pressure is back. So if it's not returning the back to the baseline, so this is not done in the proper way. So here, this is subcostal view showing this is the IVC, this is the heart, the right atrium. And in IVC here, you will find, you will put the M mode, you will see how is the collapsibility. You will measure what's the distance here and the distance here. If it is more than 50%, it's going with the fluid responsiveness. So here there is another scenario. We can 72 years old male. He is obese, diabetic, hypertensive. He has history of ischemic heart disease. Admitted as a case of septic shock as a secondary to the COVID-19. So the patient he was respiratory distress, and he developed after that hypotension. In addition to that, he has decreased level of consciousness. So we need to assess actual the fluid responsiveness. So we will go for the ultrasound, IVC, to check the IVC assessment. We found not collapsing, so we go to the lactate. Lactate actually is still high, 2.8. It was high, 2.8. So they give a fluid. Still, blood pressure is not improving significantly. So they go for passively raising. It's the same. Pulse pressure variation, it was 11. CVB, it was normal. So it's not going with the fluid responsiveness. So you have to move to the next step to add vasopressor. So here, the hemodynamic instability, it's usually in the COVID, it can be in different pathophysiology. It can, because initially it can be happened like by vasopressia. Vasopressia, it can be as a part of septic shock, or it can be from the high dose of sedation. The other, it can be, so this is the hypovolemia. It can cause hemodynamic instability, or it can be RV failure. With some patients of the COVID, they have ARDS, they are developing RV failure. COVID-19 myocarditis, it's a cause. So just here, keep in your mind, myocarditis, RV failure, hypovolemia, septic shock, or over sedation. This is very important to know the differential in the COVID-19. So what are the definition of shock? Definition of shock, actually, it's decreasing of the systolic blood pressure below 90, or decreasing systolic blood pressure more than 40, because some patients, they are hypertensive, and their baseline of the blood pressure, for example, the systolic is 150. So if he's coming now with 100, so this is considered as a part of shock. In addition to the ORS map decreasing below than 65. So the most important also, you have not only hypotension, there is an evidence of hypoperfusion. So the hypoperfusion, it can be like decreased level of consciousness, decreased urine output, patient has high lactate, so evidence of hypoperfusion. So here in pathophysiology actually of the COVID, you will initially, as it was discussed yesterday with Dr. Balshi, the initial, they have some flu-like symptoms, and 80% they are recovering with supportive therapy. But in the mid of the course, 4 to 7 days, they have developed pneumonia and hypoxemia secondary to cytokines, usually storm or high inflammatory markers. It's in a progression. The late presentation, they can develop some thrombosis, cardiomyopathy, and little evidence of hypovolemia also. In addition to that, myocardial failure, stroke, which it can be the representation. So as we mentioned, just remember the shock, it can be blood pressure below 90 systolic and MAP below 65, or systolic blood pressure decrease below 40, and there is evidence of hypoperfusion with high lactate. So what are the factors that can affect actually the MAP, or mean arterial blood pressure? So we can see MAP, it's affecting by stroke volume variation, heart rate, and systemic vascular resistance, and the CVB also, fluid status is important. So here the stroke volume variation can be preload, afterload, and the contractility itself, because if the patient has cardiomyopathy, it will affect LV failure. So this is it's important actually. Patient hypovolemic also, it will be affected. Heart rate, if it is if it is tachycardia with some arrhythmia, or bradycardia, complete heart block, it will be affecting also the decreasing of mean arterial blood pressure. But systemic vascular resistance, it will be affecting also if the patient has shock or inflammatory, it will be vasodilatation. So shock, as we mentioned just now, just we will proceed for this. So the shock pathophysiology, the shock is capacity and the pump resistance. Actually, it's important because you have to check the volume status. If the patient hypovolemic, it can causing the shock, or there is pump failure because regarding heart failure, and there is any obstruction like patient has cardiac tamponade or tension pneumothorax causing obstruction, massive PE, or there is a dilated of circulation like anaphylactic shock patient, or he has septic shock causing dilution. So here we will discuss about the capacity, like this is the normal, actually the trunk and the fizzles. So here this is the normal fizzles with good volume, but if the patient hypovolemic, the fizzles at the end it will be normal, it will be normal. But if the patient has distributive shock, distributive shock, you will find there is vasodilator, and they might associate it with evidence of hypovolemia. But if the patient has heart failure, they will you will see the trunk is full and there is no vasodilatation. And sometimes actually they can develop vasoconstriction to compensate the heart issue. Because here the types of shocks as its main two categories, recessive or distributive shocks. We can see it in different way: low cardiac output or high cardiac output. Low cardiac output, it can be from the cardiogenic itself, it can be from the obstruction like BE, we said cardiac tamponade, tension pneumothorax, or it can be distributive like septic, anaphylactic, adrenal, or neurogenic. So this is an example. We will just, for the matter of time, we will go to the next. So just we'll move to the next topic. Here, there is the Surviving Sepsis campaign. It was the recommendation. They discuss about the types of fluid and the vasopressor. Here, the acute resuscitation, they are preferring conservative rather than liberal, because the conservative is better outcome. So we should not be just giving the standard of 30 ml per kg, and if the patient not respond, give another until fill the tanks. No, you have to assess the volume status. Be gentle with the fluid resuscitation. If not responding, you can start early vasopressor. It's better than to give more fluids and more deterioration of the situation of the patient and increasing the mortality. So if you want to select the fluids, they are preferring crystalloids over colloids, because colloids is expensive and it's not changing the outcome. But crystalloids here, even if you want to use the crystalloid, buffered or balanced crystalloids, as we mentioned, like ringer lactate, it's preferred, and less renal failure, and because less hyperchloremia. But don't use starch medication fluids or gelatin, because it's dextran, increasing the acute kidney injury, and someday can increase the renal failure. If the patient is in shock and you suspect he need steroids, you can select actually hydrocortisone 200 milligram per day, either in infusion or in divided dose. So here just the scenario, a 45-year-old male with a blood pressure of 80 by 40. He's receiving IV fluid, but blood pressure, it's not that significant improving. Lactate is high. So what are the initial vasopressor? As per sepsis, you can write it in the chat, please. As per sepsis campaign, actually, they are preferring to use the first line to be noradrenaline. This is the first line. The second line is vasopressin. So dopamine is not preferred to be, or dopamine as the initial step. So the first line, actually, you can start norad. The second line, you can add vasopressin. So take home message, definition of shock, it's persistence of hypotension despite fluid resuscitation, because you will give fluid and still not responding. to and you require vasopressor like NORAD or vasopressin to improve to keep the MAP 65 and above. The most important, lactate it should be more than 2. If the lactate is not high, it's not increasing more than 2, and there is no evidence of hypoperfusion, it's not going with the definition of shock. So shock, as we mentioned, there is recessive or distributive, or you can say it in different way, low cardiac output or high cardiac output. Not all the types of shock they are fluid responsiveness. As we said, fluid is a drug, as you are flipping the coins in ICU, because almost 50-50%, 50 they will respond, the other 50 they will not respond. What is the first line of vasopressor we will need? We need norepinephrine, then the vasopressin. The recommendation of IV fluid, balance crystalloid. Thank you. If you have any question, you can just raise the hand or just write in the chat room. So I think there is no question until now. So we'll move to Dr. Basim. Dr. Basim, he's an ICU consultant. He will discuss about the essential mechanical ventilation. Actually, it's very important topic, especially for non-ICU physician to know the basic and of or the essential of mechanical ventilator. Dr. Basim.
Assalamu alaikum.
Assalamu.
Thank you, Dr. Ahmed, for the opportunity. Thanks, everyone, for attending. In this quick talk, we will try to minimize as much as we can the talk about mechanical ventilation to the essentials that allow you to understand the very basics of mechanical ventilation should you spend any time in ICU. During my talk, I will go through the indications, the goals, the types, the modes, the weaning, and the possible complications of mechanical ventilation. But I would like to start with an introduction. And I have a question that illustrates much of my introduction. I would like you to think of what are the among the following associations of mechanical ventilation. All of these are very common associations during mechanical ventilation. Which one or more of them do you think is essential during mechanical ventilation? But by essential, I mean you cannot ventilate a patient without applying it. So which ones would you choose? Oxygen, pressure, airway, or sedation and or neuromuscular blockage? Let me hear your opinion, please. Pressure. What else? It's just a brainstorming. So tell us what you think. ETT, oxygen, ETT, airway, you can choose more than one. Airway, most of participants think airway is the only defining feature of mechanical ventilation we have here. All. Okay, so if we go one by one and think of them, do we always have to apply oxygen above atmospheric oxygen or 21% during mechanical ventilation? No, not necessarily. Sometimes the patient's requirement do not necessitate oxygen. He doesn't have a problem with oxygenation. His problem is with CO2, for example. So sometimes we do ventilate patients on room air or 21% oxygen. Uh, Definitive airway is always is essential in invasive mechanical ventilation, but in non-invasive mechanical ventilation, you do ventilate patients on a mask without neither endotracheal tube or tracheostomy tube. And on the other hand, sometimes you can apply or introduce an airway like a tracheostomy tube without connecting the patient to mechanical ventilation. Sedation is also very frequent, but not necessary to mechanical ventilation. If the patient is highly cooperative, you can ventilate him without any sedation. On the other hand, sometimes you do sedate patients who are spontaneously breathing. But pressure is synonymous to mechanical ventilation. If you are applying pressure, then this is mechanical ventilation. And if you eliminate pressure, then this is not mechanical ventilation. You cannot practice mechanical ventilation without applying pressure that is higher than barometric pressure. So my message here is that pressure above higher pressure than the barometric pressure is the only essential feature of mechanical ventilation. Okay, thank you for participation. If we do understand this, and on the other hand, review quickly the physiology of breathing in spontaneously breathing or normally breathing people, then we will find that this is the exact opposite to physiology, to normal. During spontaneous breathing, we inhale air under negative pressure and exhale it under zero pressure. It's never positive except when we are coughing or something very briefly, but it's never positive in the airways normally. On the other hand, during mechanical ventilation, it is always positive, even in expiration. It is more positive during inspiration and less positive, but still positive during expiration. This application of pressure is not normal, not physiological, and the lungs are not prepared for it. And hence, it always carries an inherent harm. So my point is, when we ventilate a patient, we need to always understand that there is some harm that we cannot totally get rid of. And we have to apply mechanical ventilation for the indications which we will go for, but then keep in mind that the longer we ventilate them, the higher the pressure, the more dose. If we think of mechanical ventilation like we think of medications, then the higher the dose or the longer the duration, the more side effects you will always get. So we would always want to minimize mechanical ventilation just to necessity. The other thing is mechanical ventilation per se is just support. It does not treat the cause of respiratory failure, for example, for which we have hooked the patient to mechanical ventilation. So as obvious as this is, but it is frequently overseen by us. So applying mechanical ventilation is a bridge to it buys time to a resolution of the pathology that has caused the respiratory failure in the first time. And if we do understand that it's just to save the patient's life during whatever we are doing as definitive management, like antibiotics, for example, for pneumonia, or diuretics for pulmonary edema, or whatever we're doing, if we understand this, then we will understand that it is not at all necessary to normalize the ABG or to keep the patient in an excellent gas exchange status. You only want him to stay alive. You want to keep adequate or minimally adequate requirements running until his lung is resolved, the pathology is resolved, and his lung can take over again. And this is why during mechanical ventilation, we do not need to really strain the lung or put high pressures upon it just to normalize the ABG. This is not necessary at all. What we want to do is just to keep the patient alive. We can tolerate some hypoxia, we can tolerate some respiratory acidosis in exchange of not straining the lungs too much. So these are my two very important points I wanted to introduce before I go into the details, that mechanical ventilation is harmful, and hence it should be always minimized, and we can tolerate some deviation from a normal ABG as a price for that. If we did understand this, this is more than enough, but then I'll take you very quickly through some details of mechanical ventilation. But before I go, I want to show you these two figures that can illustrate the relationship between volume and pressure. During mechanical ventilation, what we want is volume. We want to introduce volume into the alveoli where gas exchange can take place. But the pressure, but the price we have to pay for this is the pressure. We cannot introduce volume into the lungs without applying the pressure, as we just. So pressure is a product of the volume we introduce. Now, there are two types of pressures we have to apply in order to get the volume into the alveoli where we want. There is this pressure. Look at this illustration, please, this diagram. The pipe, the pipe is the airways, and the circle is the air spaces. The air spaces, I mean the alveoli. So air goes through the airways. This includes the trachea, bronchi, bronchiole, and it also, in invasive mechanical ventilation, includes the endotracheal tube and the ventilators tubings themselves. So air have to go through this pipe and into the airspace where we want it. So there is this pressure that is needed to overcome the resistance of the tubes, and there's another pressure that is needed to distend the alveoli against their normal tendency to collapse. So alveoli want to collapse. This is called the elasticity. If you leave them alone without any pressure, they would collapse. So you want to open them, and this has to be applied through the pressures. So these are two distinct pressures you have to go. The first pressure, the one that has to do with going through the tube, is called the resistance, and the flow. It has to do with the flow, which is the speed at which air is going into the lungs, and by the resistance of the tubes themselves. But if you hold the flow, if air is not coming or going, if you have introduced already your tidal volume into the alveoli and then stopped the breathing cycle with no inspiration and no expiration, then the flow is zero, and hence the whole first pressure is eliminated from the equation. And this leaves us also only with the pressure needed to distend the alveoli. This pressure, the other pressure, we call it the alveolar or the plateau pressure. And this is the most important pressure we keep following always during mechanical ventilation, because it directly correlates with mortality, and this is evidence-based. So regardless of the peak airway pressure, which is the higher pressure reached in airways during the respiratory cycle, the important one is the alveolar or the plateau pressure. And the alveolar pressure is the product of the volume you introduce, how much air you want during tidal volume, and the compliance, which is the ability of the alveoli to distend in response to pressure. So the lower the plateau pressure, the better. But the cutoff we usually follow in the ICU based on many substantial evidence is 30. So we always want to manage our volumes and our rates and settings in general to keep the plateau or the alveolar pressure below 30, because it has been proven that this improves outcomes, especially in ARDS, where the lung is very stiff or the lung compliance is very low. Now to some details, starting with the indications. So obviously, the first and most common indication of mechanical ventilation is respiratory failure, whether it is type 1, where only hypoxia is there, or type 2, where hypoxia and hypercapnia are both there. But also, very frequently, we do ventilate patients just to protect the airway. And in this scenario, what the patient really needs is an endotracheal tube, not necessarily mechanical ventilation. But you cannot intubate a patient, but then not ventilate him. So this is another major indication. And the common examples of this is coma, where the patient is unable to protect airway and hence he's intubated and ventilated. So in most cases, like if we think of a patient with severe traumatic brain injury, for example, he's unconscious, he's unable to protect airway, and hence he gets intubated and ventilated. Now, this patient's cardiopulmonary function is normal. It's not affected at all, and he did not necessarily need mechanical ventilation, but what he needed is intubation. You intubate him and then you ventilate him. This applies to conditions like airway edema, like trauma to the airway, like severe hematemesis. So, and this goes on. The third major indication of mechanical ventilation is trying to balance oxygen delivery with oxygen consumption. And this is specific to shock states where a patient, let's think of a patient who is in shock due to a urinary tract infection, for example. So this patient is fully conscious, he is protecting airway, and he does not have pneumonia. His gas exchange abilities are normal. Yet, if he is in severe shock, so we do intubate and ventilate him. And doing this, we are trying to improve his oxygen delivery and minimize his oxygen consumption at the same time. Improving oxygen delivery is obvious. By mechanical ventilation, you improve the patient's saturation and hence the oxygen delivery. But also during mechanical ventilation, you can decrease the oxygen consumption by taking off the work of breathing of the patient and doing this through mechanical ventilation. Work of breathing can account to up to 30% of the total oxygen expenditure during shock states or severe dyspnea. So, sorry, by connecting to mechanical ventilation, you decrease the patient's work of breathing and hence oxygen consumption. And also, during mechanical ventilation, you can sedate and or paralyze the patient, decreasing his muscle, skeletal muscle expenditure of oxygen. So these are the three major categories of indications. If we are planning for mechanical ventilation for whatever indication, we need to set goals like any intervention. So the two obvious goals are maintaining oxygenation and controlling the CO2 elimination. And you can maintain oxygenation by manipulating the FI2, which is the concentration of oxygen you deliver during mechanical ventilation, and or the mean airway pressure. So the higher the FI2 and or the mean airway pressure, the better oxygenation you can get. The second one is controlling CO2, and this has to do with the tidal volume and the respiratory rate. So the bigger the tidal volume you deliver, and the more frequent the rate, the more you wash CO2, the less CO2 in the ABG and the less respiratory acidosis you get. Remember that the tidal volume and the rate together, the tidal volume multiplied by the rate is what we call the minute ventilation, which is the total amount of air inspired and expired by the patient during a full minute. So sometimes you can increase the volume and decrease the rate, or the opposite, to maintain the same minute ventilation based on your settings. But while maintaining oxygenation and CO2, we need to improve the patient's comfort, and this can be achieved through wise use of sedation and analgesia. And we always need to keep in mind what we said initially, that mechanical ventilation is harmful, and then we have to always keep strategies designed to minimize the harm of mechanical ventilation during the course. If the patient needs mechanical ventilation, the first question should be whether he needs invasive mechanical ventilation or he can be ventilated on non-invasive mechanical ventilation. At the beginning, we said you want to always avoid, if possible, mechanical ventilation altogether because of the harms, and if it is necessary, you want to minimize it. But what exactly you want to minimize in mechanical ventilation? You want to minimize everything, starting with invasiveness. And hence, non-invasive mechanical ventilation can be thought of as superior to invasive mechanical ventilation in suitable patients. And this is reflected on patients' outcome, that for suitable patients, non-invasive mechanical ventilation has better outcomes than invasive mechanical ventilation. What are the major, most studies and most established indications of non-invasive mechanical ventilation? There are three: cardiogenic pulmonary edema, COPD exacerbation, and obstructive sleep apnea. However, very frequently, non-invasive mechanical ventilation is used for other indications. And this is derived by the understanding that the less invasive, the better. So what really governs whether or not we can apply non-invasive mechanical ventilation is not the indication, it is rather the contraindication of mechanical ventilation, which is to say, if the patient does not have a clear contraindication to non-invasive mechanical ventilation, it sometimes is reasonable to try uh, to try non-invasive mechanical ventilation, or, even if it does not have one of these major indications. But if there's no contraindication and you feel that it will minimize the harm, then sometimes you can give a trial of non-invasive mechanical ventilation. So contraindications of non-invasive mechanical ventilation, unfortunately, are very frequent. These are just some examples of them. So if the patient is not able to protect airway, if he's not cooperative, if you cannot find a perfect fit, a mask that fits the patients well, if the patient is hemodynamically unstable, if there's severe metabolic derangements, if the patient cannot handle his own secretions, or if he has local trauma or burn to the face, then you cannot apply non-invasive mechanical ventilation. And in short, you can say that any patient who is really sick is not fit for non-invasive mechanical ventilation. And this explains why, although we understand that non-invasive mechanical ventilation is less harmful, but you will not find many patients on non-invasive mechanical ventilation on the critical care department. And this is because our patients are mostly critical and not fit for non-invasive mechanical ventilation. I'm sorry. What are the complications of non-invasive mechanical ventilation? Again, these are just some examples of the complications. These include pressure ulcers on the face. Some patients have claustrophobia. Abdominal distension is almost always does happen in patients because some of the air is swallowed rather than inspired. This can lead to aspiration, and there is almost always, impairment of nutrition during the period of non-invasive mechanical ventilation. I'm sorry, give me 2 minutes, please.
Dr. Bassem?
I'm very sorry for that. I needed water. Okay, so but the most important and dangerous complication of non-invasive mechanical ventilation is delaying intubation when it is necessary. So non-invasive mechanical ventilation has the potential to mask the deterioration of a patient. And in inexperienced hand, it can be very dangerous if we apply a non-invasive mechanical ventilation to a patient who is not necessarily fit or eligible to non-invasive. And then when you do, most of the time your situations will improve, and you may think the patient is improving while he is in fact deteriorating. And this would dictate later emergency intubation rather than elective intubation and delayed intubation, which carries worse outcome. And this is why non-invasive should or patients should be selected carefully for non-invasive mechanical ventilation, and more importantly, monitored very frequently during the first 2 hours with frequent ABGs and examinations to make sure that the patient is benefiting from non-invasive mechanical ventilation rather than deteriorating. On the other hand, if we choose to start invasive mechanical ventilation, then this is a very brief introduction to the major basic modes of mechanical ventilation, and we will discuss 3 of them. These are called volume control, pressure control, and pressure support. First, the word cycled is describes how the inspiration ends, how the ventilator ends inspiration and starts expiration. So when we call volume control, we call it volume cycle. We mean that the ventilator would end the inspiratory phase and start expiration when it reaches the target volume. And this is why we call it volume control. During volume control, you set your ventilator to deliver a specific amount of air. This is the tidal volume. And after delivering the full amount, then the ventilator switches to expiration, allowing this air to come out. Please notice that during volume controlled mechanical ventilation, you target the volume and you watch the pressure. You cannot control both volume and pressure at the same time. So if you choose to control volume, then you have to watch, monitor, and try to minimize or limit the pressure, but you cannot control it. Volume controlled mechanical ventilation is described as controlled mode because all the breaths are mandatory. Mandatory breath means that it is not the choice of the patient. The patient can ask for a breath, which we call it triggering, but then he gets a pre-described breath that we set, a certain volume, a certain inspiratory time, a certain inspiratory to expiratory ratio. So all the breaths are controlled by mechanical. There's no spontaneous breath at all during this mode. The other frequently used and popular mode of still controlled mechanical ventilation, which means not spontaneous, is pressure control. And in pressure control, it's the opposite. You target pressure, you monitor volume. But we call it time cycle because inspiration ends after a preset time under a preset pressure. So you choose the inspiratory time and the target pressure you want, and then the ventilator applies this pressure for this set time and then switches to expiration. So during the increase of pressure to what you have chosen for this time, air flows into the lung and giving the tidal volume. But then the tidal volume in this mode is just a product of the pressure you are applying. So you do not exactly know how much volume the patient will get. You can monitor it, but you do not choose how much. You just choose the pressure, and volume will be a product of that. It is again a mandatory or controlled mode where there's no spontaneous breathing. Any of pressure controlled or volume controlled is suitable to start mechanical ventilation on during the period the patient is very sick and needs maximum support. But they are not suitable to end mechanical ventilation where the patient is improving and you think of weaning. There are other weaning modes. Which one is better? There's no evidence-based preference. It's usually a personal and institutional preference, but there's no superiority in terms of outcomes between pressure control and volume control. In our institute, we use volume control more frequently, but pressure control is an acceptable alternative. The third popular mode is a weaning mode. It's called pressure support. In pressure support, as the name indicates, is just a support. It supports the ventilator, supports the patient with pressure, but it does not give the breath. The patient has to breathe spontaneously, supported by the pressure the ventilator is applying. So it is a spontaneous mode, and hence it is not suitable to initiate mechanical ventilation on. It is rather suitable to end it or to wean the patient on it. It is actually the most popular weaning mode. It's called flow cycle because inspiration ends after a certain drop in the flow during inspiration. So how do you initially set your ventilator? As we said, you would always start with a controlled mode or assist controlled mode, which is volume controlled or pressure controlled. You would always start on 100% oxygen. You can decrease it later if the patient is over oxygenation. Most of the time, you would start with a minimal PEEP, and PEEP is the positive end expiratory pressure or the lowest pressure that happens during the end expiration or in the whole respiratory cycle. So 5 is generally considered as minimal. Most ARDS patients would need higher PEEPs than this, but most of the time you start on 5 and then you increase it as the patient needs. And then you get to set your volume. And in volume, you need to ask yourself first whether you think this patient has ARDS or does not have ARDS. So in ARDS, it is evidence-based that lower volumes of 4 to 6 milliliters per kg of ideal body weight carry better outcome to the patient. So if the patient has ARDS, you start at lower volumes. And remember that the volume is a major determinant of the CO2. So if you choose to start with low volumes because you think the patient has ARDS, then you will probably have to start with higher respiratory rate to compensate for the minute ventilation. But if the patient does not have ARDS, then you can start with higher with higher volumes of 8 to 10 milliliters per kg of ideal body weight and lower respiratory rates. So this explains that the respiratory rate is you first set the volume and then you set your respiratory rate to try to maintain your minute ventilation initially as 80 to 100 milliliters per kg. After your initial settings, you monitor the patient, you take an ABG, you check the pressures on mechanical ventilation, and then you adjust accordingly, according to the patient's needs and the pressures you get. You can change your settings based on that. Weaning of mechanical ventilation starts by appreciating that the patient has improved in terms of the initial cause. So this is very important to keep in mind. If the patient is intubated because he has pneumonia, we shouldn't be thinking of weaning before his pneumonia has improved. Finding that the patient is on low settings or conscious or hemodynamically well, that should not cause us to start weaning unless the initial cause has improved. So if this has happened, pneumonia has improved, coma, the patient has been unconscious, he regained consciousness. So whatever the initial cause was, if it has improved, then you need to look to the contraindications of weaning. If any of these contraindications exist, then you cannot proceed with weaning. So if any patient is on high settings or experiencing hemodynamic instability, if he has severe metabolic derangements, cannot protect airway, he has a weak cough, cough reflex, if his X-ray is very bad, then you cannot proceed for weaning. But if there's no contraindication, if the initial cause has improved and there's no contraindication to weaning, then you can proceed with what we call the spontaneous breathing trial. This is when you switch your mode on mechanical ventilation from a controlled mode, volume or pressure control, to a spontaneous breathing mode, spontaneous mode, most of the time on pressure support, as we said, and you give the patient a time window of half an hour to 2 hours to breathe spontaneously, supported by mechanical ventilation, and you monitor the patient while breathing spontaneously. If he maintains his saturation, ABG, he doesn't get very distressed, tachycardic, tachypneic, shallow breathing, many indications of failure of the breathing trial. If he developed any of these, then the trial has failed and you go back to a controlled mode. But if the patient breathes well spontaneously, then this is the time you can proceed for extubation. My final slide, and I know I have passed my time. There are many complications of mechanical ventilation. Sometimes they are not a part of mechanical ventilation per se. These are the complications of airway or the complication of sedation. So these are common associations, but these are not the complications of mechanical ventilation per se. But complications of mechanical ventilation itself are multiple, and they include what we call ventilator-induced lung injury, barotrauma, volutrauma, atelectrotrauma, and or biotrauma. These also include infection, ventilator-associated pneumonia, or ventilator-associated tracheobronchitis. It includes diaphragmatic atrophy, which almost always happens very early during mechanical ventilation. When the patient is dependent on mechanical ventilation, his diaphragm tends to thin out and gets weaker, which complicates or makes it more difficult to wean him later on from mechanical ventilation. So these are the major complications among many other complications of mechanical ventilation, but these are the ones you need to always keep in mind. Ventilator-induced lung injury most of the time has to do with the settings you choose. Diaphragmatic atrophy is invariable, and the ventilator associated pneumonia has to do with the common practice of lung hand hygiene, and contact precautions, and has to do with the period or the time on which the patient is ventilated. I think this concludes my talk, and I'm happy to receive any questions. Thank you.
Thank you, Dr. Basim, for your lecture. Actually, it's very informative. So, if there is anyone has a question, they can write in the chat room.
Thank you then. There is a question?
Just there,
No.
it's very informative, and thank you.
Thank you.
I think it's the clear the lecture. You make it simple, and maybe they are understanding it properly. Actually,
Hopefully. Thanks a lot.
yeah. Thank you.
Thanks
Thank you.
for
So
having me today.
Thank you. Thank you for Dr. Basim for his very informative lecture, and it's very important. So now we will move to the third lecture. It will be with Dr. Bashir Abdurrahman. He's a clinical pharmacist, and especially for ICU. He will discuss about pharmacology of COVID-19. So you will get a lot of information from him and the most updated medication and about the protocol of MOH for the treatment of COVID-19.
Thank you, Dr. Ahmed.
Yeah.
Thank you, everyone. I will start sharing my slides. Okay. Okay. Thank you for having me today. I'm Dr. Bashir Abdurrahman, ICU clinical pharmacist. I will quickly start with my lecture. It's related to medications we are using with COVID-19. As you know, till now, we don't have any proven medication for COVID-19, specifically for COVID-19 virus. But we are using some supportive therapy, and we are using some antivirals trying to reduce signs and symptoms and the complications of the disease and to inhibit the replication of the virus with those therapy. A simple introduction regarding the COVID-19. It's a virus attaching to the receptor binding gene region that same of SARS coronavirus, and that's why it's called SARS-2. And the virus has been shown to use the same receptors, which is angiotensin converting enzyme 2. As you know, there is many talk about angiotensin ACE inhibitors and ARBs. Are we using those medications to treat coronavirus or COVID-19? Of course not. We are not using those medications. But as you know, we should not stop the using of those medications for hypertensive or heart failure patients. So if they already on those medications, we have to continue with those agents. Why? Because we think that with those patients using ACE or ARBs, they will have overexpression of those receptors, angiotensin converting enzyme 2. So they will be more invaded with the virus. So we recommend to continue using those blockers to decrease the severity of the disease. So it's not an anti-COVID-19, but it should be continued to decrease signs and symptoms. Its RNA is very close to or similar to bat coronavirus. That's why they think that the source is unfortunately, it's a positive sense RNA virus and enveloped virus. This is very dangerous issue because this means it's very easy to attach, very easy to replicate, and it's not easy to fight or to treat. I think you can see the spreadness of this virus is very potent and very fast. I think the main idea regarding, or the main reason, because it's enveloped with positive sense RNA virus. Severe illness, not exclusive for advanced aged people. I think we have now good idea regarding to this. Many ICU patients, they are young. So it's not only related to the advanced age. Of course, those patients with comorbidity more predominant to have severe disease, but it can happen with both young and advanced age people. Some patients with comorbidities will have more severe symptoms. We think there is two factors with this. Of course, most of them will be immunocompromised, or they will be cachectic for any pathophysiological changes. And the other thing, there is many supportive therapy and treatments we will not be able to give, or we will be with severe caution to give for those medications, like those with renal impairment, liver impairment, or cardio myopathy. Those patients, we will make special issues while we are treating with those antivirals and other supportive agents. Why we are not finding or why we don't make a drug or find a treatment, it's not an easy thing. Usually, to approve a new drug, we need at least 12 years to be approved by FDA. But now we have something called fast track, that we will give a license or approval to be used as unapproved use or unapproved medical countermeasure. So till we have the approved medication, we need 12 years, but we may have unapproved medication that effective for COVID-19 within a year or couple of years. Okay, management. We have two types of patients. We have home care and we have hospital care. Home care, the most important issue to focus on prevention of transmission to others and monitoring of the clinical deterioration if occur, and hospitalize in the proper way. So mainly management will be hydration, good hydration, antibiotics, and analgesics. But regarding to hospitalized patient or hospital care, we have a lot of issues like glucocorticosteroids or steroids in general, nebulized medication, NSAIDs, antimalarials, antivirals, interleukin-6, convalescent plasma, and supplement like vitamin C, vitamin D, and zinc sulfate. We will go very fast with those. Unfortunately, with SARS and influenza, we have very bad glucocorticoids. Those medications will increase the viral load and delay the viral clearance. So we think that we should not use with COVID-19 patients. WHO and CDC recommend the glucocorticoids should not be used as a usual management of COVID-19 and pneumonia. But you know, yesterday we have a very good news and big trial, the British trial, that they found with those with pneumonia and any respiratory symptoms, even if not intubated patient, they will get better with using corticosteroids. So now, according to our MOH protocol and according to the new study, we can use corticosteroids, especially dexamethasone, small dose, with those patients with COVID-19 and respiratory symptoms. If they have respiratory symptoms, desaturation, or they are intubated, you can use small dose of corticosteroids. And if they are in ARDS, we will manage ARDS as we are managing our patients. And if there is septic shock, we will manage those as, and we will give hydrocortisone or hydrocortisone, yes, according to septic shock management. So related to COVID-19, mild patient, asymptomatic patient, we should not use corticosteroids. It will increase viral load or it will delay the viral clearance. But with respiratory symptoms, we can start small dose. This study showed that with those non-intubated patients, it will decrease mortality by 1/5, which is 20%. And for ventilated patients, it will decrease mortality almost by 1/3. So it was very efficient drug, dexamethasone 6 milligram. But if there is ARDS or septic shock, we will use the doses of ARDS and septic shock. Regarding nebulized medications, we have this procedure, as you know, aerosol generating procedure. So we are trying to avoid. If we have to give bronchodilators, we need to use meter dose inhalers. Those will not generate aerosols. So if we have adjunctive therapies like antibiotics, nebulized antibiotic, and acetylcysteine, we have to stop as much as we can. We should not use unless it's a very necessary issue for the patient. So usually we will stop any adjunctive therapy as nebulizer, and if there is a bronchodilator, we will shift to meter dose inhaler, and we are avoiding any aerosol generating procedure. So nebulizers usually we are trying to avoid. NSAIDs, I think 3 months ago, on 18th of March, WHO published this warning that according to the French French scientist comments that we should not use NSAIDs, especially with young patient. It shows that young patients used NSAID experience severe disease. Later on, with more data, we found there is no contraindication to be used, and by EMA, WHO, EMA, which is European Medicines Agency, and WHO do not recommend that NSAID should be avoided for those with COVID-19, but it will be the second choice. So we suggest to start with acetaminophen, which is paracetamol. You can use as antibiotic, and you can use NSAIDs as needed with lowest effective dose, not to be the first agent therapy and to give it in a high dose. So we can use it, but second line agent or second choice with lowest effective dose. And if there is a chronic use, like those patients with rheumatoid arthritis or whatever, anything else, chronically using medication, they can continue unless there is contraindication not related to COVID, like GI bleeding. So with the chronic patient, continue. If COVID patient, you can use paracetamol as the first line antibiotic agent. If failed, you need to use another thing. You can use NSAID with lowest effective dose. Regarding chloroquines and mainly we are talking about chloroquine and hydroxychloroquine, those antimalarial drugs. Usually we used to manage, we used to use as management to minimize symptoms of inflammatory immune diseases such as lupus and rheumatoid arthritis. In vitro, they found that hydroxychloroquine mainly and chloroquine to some level, they can prevent SARS-CoV-1 and 2 viruses from attaching and entering cells, which is a very good advantages. I think that's why we are using now those agents in only in mild stage. Mild stage, still we are in a phase that we need to prevent the attachment of the cells and the entering of the cells. So hydroxychloroquine we are still using for this one. But unfortunately, there is some side effects like QT prolongation. So there is a lot of controversy about using hydroxychloroquine and chloroquines in general, and we cannot decide is it really beneficial till now or not. So if there is any major risk, we are avoiding to use hydroxychloroquine or chloroquine. So if you have young patient, mild symptom or asymptomatic, and with the QT prolongation, we are not starting hydroxychloroquine for this patient. But if you have comorbid patient and advanced age, and they are in mild phase, and you are suspecting this patient will deteriorate maybe because they are immunosuppressed or immunocompromised, I think it's wise to start hydroxychloroquine with monitoring of the QT. Both of them were effective, but as I mentioned, hydroxychloroquine appears to have more potent antiviral activity. FDA initially given this drug emergency use authorization yesterday or the day before yesterday, they withdrawn this authorization. Now it's not authorized, and we are using in unapproved, unauthorized indication, but we're still using according to our MOH protocol. So they did not say it's you should not use. They mentioned we see that or we can till there is no data about its efficacy, and we cannot give him the authorization, because if you have the FDA authorization, so you are using it in its one of its uses. Now we are using it in unlabeled use. Optimal dosing, usually we are giving 400 BID, which is 800 in day one, then 400 milligram daily, which is 200 BID. Then after 4, 5, or 7 days. For chloroquines, we are giving 1 gram, then 500 But if we are using chloroquine base, the dose will be 600 milligram and 300, because chloroquine sulfate with salt, the dose will be 1 gram with but without salt, only base, the dose will be 600 milligram. Please take this in your consideration if you have to prescribe it. As I mentioned, primary data showed that some data, but not yet approved, that hydroxychloroquine will decrease or faster time to improvement in fever, cough, and chest imaging. So some clinical data showed there is some benefit of hydroxychloroquine. Regarding adverse drug reaction, almost 90% of the patient will not show or will not have any of chloroquine's side effects, but we are mainly looking for some ophthalmic and cardiac issues, so we have to monitor, especially QT. We have also some other agents that may prolong QT, like antivirals. We are using Calerta, which is Calitra, which is leponavir, ritonavir, and azithromycin, of course. Those also will prolong the QTC. That's why we need to adjust sometimes and discontinue some of those agents if it was there to avoid more QT prolongation. As I mentioned, drug toxicity, mainly retinal toxicity and QT prolongation. And there is a lot of drug-drug interactions. That's why usually we are checking drug interactions for all patients with hydroxychloroquine to avoid major toxicities like QT. How to start chloroquines, let's say for those patients here on the left, if the QRS is low or normal 120 or less. So if a QT more than 500, I will contact cardiologist before I will start chloroquine. If between 470 and 500, I will check drug-drug interactions and I will start with caution. I will try to avoid any other agents that may prolong the QT. And of course, daily QT prolongation. If a QT less than 470, I will start immediately. But if we have prolonged QRS more than 120, 550, I will not start till I have the clearance from cardiologist. If between 520 and 550, I will start, but I need to check drug-drug interaction and discontinue any other medication that can cause a prolongation. If a QT less than 520, I will start immediately. Of course, regardless anything, you have to do a daily ECG, and you will stop immediately if the QTC increased more than or by more than 50 once. Let's say it was 420 and it's now 480, I will stop. Even with other patients, I will start with 480, but because of this jump, I will stop. Here, the only thing I want to mention that you have to optimize electrolytes like magnesium, potassium before you will. It's not only to be normal, because 3.5, it will increase the risk of the prolongation. So optimizing magnesium and potassium will decrease the risk of QT prolongation. Finally, regarding chloroquines, that ophthalmic retinopathy, hematological and oncological issue, hemolysis because of the G6PD, we need to send the test, especially if we are using chloroquines. It's much lower with hydroxychloroquine and no need to send the test unless you are suspecting hemolysis. Leukopenia, thrombocytopenia, endocrine, this is a very important issue. If you are using chloroquines with patient with insulin, you have to reduce the dose because usually those patients will develop severe hypoglycemia because of the insulin interaction. Cardiovascular, we mentioned enough regarding prolonged QT, respiratory bronchospasm, and hepatic. We are seeing a lot of abnormal hepatic function test and acute hepatic failure. As I mentioned, insufficient data thus far to know whether hydroxychloroquine or chloroquine has a role in treatment of COVID-19. طيب, there is many multi-center studies, or let's say 2 or 3. Most of them show that there is no extra benefit. And you know about the Lancet study, the famous Lancet study, this 90,000 patients. It showed that it may increase in harm. But the Lancet, again, they apologize about this study and they withdraw it. Then it came back to the protocol. So there is a lot of controversy regarding to this, but for now we are using this chloroquines for mild to moderate cases to inhibit the entry of the virus to the cell. Regarding remdesivir, this is the new hope, but unfortunately it is not an ICU drug. I will mention now why we are not why we are saying this is not an ICU drug. Even it's rule only for critically ill patients in the protocol. طيب, remdesivir broad spectrum novel nucleotide analog activity against a lot of virus. One of them SARS-CoV-2. Usually we are giving loading dose to 100 milligram, then 100 milligram once daily for 2 to 10 days. It was tested for Ebola, MERS-CoV, and SARS before. Mild side effect, but unfortunately we have some toxicity regarding to cyclodextrin vehicle, because it's dissolved in cyclodextrin. So if there is acute renal impairment, we will have the toxicity. When to exclude the use of the remdesivir, why it's not an ICU drug? Because if we have multi-organ failure, you need for inotropes, you have to exclude the use. If creatinine clearance is than 30, you have to exclude the use. If dialysis or hemofiltration, you have to exclude the use. If there is liver injury, but severe, the enzymes more than 5 times upper limit, normal, so you will exclude. Also contaminant use of another antiviral, you have to exclude. We are waiting if they will allow us to have exceptional use for those, but until now it's prohibited or not recommended to be used with those patients. And if it will be used for critically ill patients, which is multi-organ failure, I don't know if we will have this exception or not. But till now we don't have it here in Saudi Arabia, and till now we are not using it for critically patient. طيب, what about data regarding to remdesivir? I think it's likely has some clinical benefits. Why likely some clinical benefits? The largest study in the US, more than 1,000 patients, showed that remdesivir will faster time to recovery, 11 versus 15 days, which is a good outcome, but it will not decrease mortality. Even there is some trend toward lower mortality, but unfortunately with this number of subjects, more than 1,000 patients, and statistically non-significant, I think this is very important issue to mention. So it failed to improve mortality. And another study in China, 237 patients with severe COVID-19, which is the most important for us, had similar time to clinical improvement and similar mortality rate. So there was no benefit for severe patient regarding or according to the Chinese study, and according to US study, it will faster time to recovery only, but it will not decrease mortality. This is about remdesivir. Lopinavir, ritonavir, you know now that we are using this in the triple therapy. There was one study supporting the triple therapy, and it was a good study, but unfortunately for also non-severe or non-critical patients. Regarding to sole use as a monotherapy, lopinavir, ritonavir should not be used anymore, because there is a lot of data regarding it was useless to be used as a monotherapy. In this study, it showed there was no difference in time to clinical improvement or mortality with using the lopinavir, ritonavir, and it was a randomized trial. So according to ESCM, European Society Intensive Care Medicine, and the Society Critical Care Medicine, Surviving Sepsis campaign. All those associations recommendations suggest against the routine use of lopinavir ritonavir in critically ill adults with COVID-19. So we are not using this agent but only with a triple therapy, interferon and ribavirin with the lopinavir ritonavir. Regarding favipiravir, new agents, we have it now in Saudi Arabia. It's an Asian agent, only available in Asian countries, RNA polymerase inhibitor. In a study for non-severe disease with auto-saturation more than 93%, favipiravir was associated with faster rate of viral clearance and more frequent radiographic improvement. So it was efficient and effective, but for non-severe disease, for those patients with saturation more than 93%. Limitation, it was not a non-randomized open-label study, and the result should be interpreted with caution because there was many other measurements the patient and other therapies the patients are taking. Absolute contraindication with the pregnancy and even with male, they must avoid intercourse for at least 4 weeks after taking this medication. Regarding triple therapy, the interest, of course, those are interferon beta 1b, ribavirin, and lopinavir ritonavir. The interest with the interferon beta started with SARS-CoV-2 because it was used with MERS-CoV in 2013. This randomized trial in Hong Kong, they found that in 127 patients, 80 of them took the triple therapy and 40 the standard therapy. They found that the triple therapy will improve symptoms and it will fasten the clinical. They have fasten clinical improvement with median 4 versus 8 days, and discharge from hospital median 9 versus 15 days. So it was efficient, but also regarding to signs, symptoms, and hospital discharge, nothing related to mortality till now. And we need to try it with severe patient to check. But unfortunately, we are facing a lot of side effects with this triple therapy, so we have to monitor closely this one. Regarding hemolysis, we are afraid that ribavirin will cause. We are using a small dose for 100 milligram BID, not like those we are using with hepatitis, up to 2 grams. So there was no hemolysis reported. Regarding convalescent plasma, this is, I think, something logical that you will take antibodies from recovered patients and you will transfer 200 or 300 ml of the plasma to the infected patients, and it will help with fighting the disease and to recognize the immunity system to replicate those antibodies. And it's a hopeful thing, but we have only small data regarding to this, only small studies with 19 patients and 5 patients, but the data was good regarding to moderate to severe patients. Some of them were intubated and recovered, but unfortunately we cannot start till now with this because a lot of logistic challenges, finding appropriate donors and establishing tests to confirm neutralizing activity, that you need to know the titer, how much antigen are there, antibodies are there, and you will IgG, IgM before you will transfer to the patient and you will tell this one failed or not. So a lot of logistic issues. So we need to wait for it. We have now in KSMC 5 kits, and I think we will start by tomorrow or the day after tomorrow to use it for 5 patients. Interleukin-6 pathway inhibitor, tocilizumab. Unfortunately, we have a lot of issues with availability now, but the main idea, it's not antiviral or anti-COVID-19, but it will decrease the complications of COVID-19. Cytokine release syndrome, one of the fatal complications of COVID-19. So when we are using this interleukin-6 pathway inhibitors, we will decrease the mortality of this disease. only one small retrospective study, but it showed some activity when we are using probably the cytokine release inhibitor or the interleukin 6 pathway inhibitor tocilizumab. There is another cetuximab and sarilumab, but we don't have it here in Saudi Arabia. I think, at least we don't have it in KSMC. The only one available to tocilizumab, but unfortunately it was available for rheumatoid arthritis patient, not for the indication of COVID-19. So we are waiting the availability of this drug. There is some criteria when to mention this patient in cytokine release syndrome. I think we can share on the group if you want. Regarding vitamins, vitamin C, vitamin D, and supplement with trace elements like zinc. We don't have specific data related to COVID-19, but we have previous data regarding ventilated or mechanically ventilated in critically ill and critically ill patients. We can see here, of course, you know, there's a lot of advantages and benefits of vitamin C. We need only 0.1 gram per day of this drug, but in ICU, if we are giving to our patient, it will reduce length of stay in ICU by 7.8%, and it will shorten the duration of mechanical ventilation up to 18%, which is very significant. But the dose will be 1 to 6 gram per day. That's why we are giving 1 gram BID or 1 gram TID. But regarding to COVID-19, there is no solid evidence. There is no studies regarding the efficacy of vitamin C with COVID-19 patients. Type. Okay. Regarding our C1 protocol, I think you know that if suspected patient, we will deal as regular patients. But if a confirmed case, we will start the prophylaxis. DVT prophylaxis is very important. I will show you the new, the updated guideline protocol from MOH for adult. Okay, this one just released today morning, as I know. Same, we have this one the same as our protocol in case I think cluster 1 protocol. So you can find the same, but here I think you can see immediately. Now, regarding to the dimer, we will check the dimer. If less than 1, and according to the weight, you can use noxaparin 40 once daily or 40 twice if the weight more than 100 to 150, more than 150, 60 BID. But if the dimer is high, less than 100, we will use BID dose, 40 BID, and if 100 to 150, you will use 80 milligram twice daily, and more than 150, 120 milligram twice daily. Of course, with normal renal function. If there is acute renal impairment and creatinine clearance less than 30, or patient on anuric or on dialysis, we will shift to heparin according to our protocol. If there is any contraindications of heparin in general, low molecular weight or unfractionated heparin like HIT, you can use other agents like apixaban or bevalorudine if we are using as treatment, or argatroban. Okay, this is the MOH protocol regarding to anticoagulation. I will go through last thing in my lecture. I will go quickly through the protocol regarding to the medications. Asymptomatic, we will not treat, no requirement for any treatment. But for those mild to moderate, we will start triple therapy or favipiravir or chloroquines. You can start hydroxychloroquine. Here in KSMC, we put that we agreed with the ICU and ID to put the hydroxychloroquine like the first agent for mild to moderate, because we are trying to save other agents like favipiravir and triple therapy for severe and critical patients. So we are using this one. Some cases we are giving for hopeful and with few days with symptoms, we are giving favipiravir. because it was mainly efficient with those with auto saturation more than 93%. Okay. Regarding to severe cases, those with respiratory signs and symptoms, oxygen saturation is than 93. By the way, it's 90 here in our protocol. BO2, FiO2 ratio is than 300, lung infiltrates more than 50%, and respiratory rate more than 30. Now we will start with triple therapy, no role for chloroquines here, and alternative, we will start favipiravir. Mainly here in KSMC, we are using the triple therapy for those patients. For critically ill, okay. And here also, when we start the, if we start the respiratory symptoms, we will start dexamethasone 6 milligram once daily for 10 days. Of course, we can use also prednisolone, methylprednisolone, hydrocortisone, but we have to convert the dose. For critically patient, those with multi-organ failure or altered consciousness, sepsis, ARDS, we can consider, of course, the use of antibiotic and antifungal, of course, for those patients with septic shock, and tocilizumab with those with cytokine release syndrome or STORM. The primary agent to be used remdesivir, but unfortunately we don't have it once available. We can consider the use of favipiravir here also for those patients, and there is no rule for the use of triple therapy for critically ill patients anymore. So only remdesivir or favipiravir. Of course, we will use dexamethasone for those ventilated or in ARDS patient. But in ARDS, we are using higher doses than that because we are treating ARDS. But if only ventilated and respiratory symptoms, there's no ARDS, we are using 6 milligram once daily. If cytokine release syndrome, we are starting tocilizumab, maximum 2 doses. Usually we are starting 400 to 800. Maximum is 800, usually 400 to 800 per dose, IV infusion. And I think this is the end of my slides because almost the same protocol. Thank you. Questions?
Thank you, Dr. Bashir, for your lecture. Please, if anybody have any question, you can write in the chat room, please.
Okay.
Okay, thank you, Dr. Bashir. Thank you so much.
Thank you very much. Thank you.
So now we will move to the next lecture about acute respiratory distress syndrome. So this lecture was prepared by Dr. Omar Ramadan. I will present on his presentation. So here, the definition actually of ARDS. Sorry. Just for a while, please. So here actually, this definition as per North American European Consensus Conference, it was the criteria. It is an acute and persistence. In addition to that, there is radiological finding, which is bilateral infiltration, consisting with presence of edema. And also regarding the oxygenation part should be the BaO2 over FiO2, the fraction of oxygen ratio should be below 300. Or acute lung injury and also the BF ratio below 200. So there is an exclusion criteria if there is any left atrial hypertension or pulmonary wedge pressure 18 or more. So this is an example, the X-ray showing there is bilateral infiltration. Then later there is the Berlin definition came regarding the acute respiratory distress syndrome. So this is uh, discussing about the time, the definition, the time it should be 1 week or low. There is a new bilateral obesity. And also this origin of erythema should not be cardiogenic. It should be from normal, it's not cardiogenic or volume overload. It should be from the infiltration of the lungs. So the oxygenation, as it's divided according to the BF ratio to 3 stages, mild, moderate, or severe. So the mild, if it is 200 to 300, and moderate 200 to 100, and severe below 100. And all of them be required should be 5 and above. So actually the mortality when the severity is more, the mortality will be higher. Like if it is mild, the mortality is 27%, but if it's severe, reach up to 45%. So what are the common causes of ARDS? Actually, the most common causes here, pneumonia, sepsis, trauma, and inhalation injury. So the pneumonia is the major, 40%, but 22 the sepsis, then the aspiration pneumonia, after that doing the trauma and others. Actually, the transfusion and the trial, it's only 5%. So here it can be direct causes or it can be indirect causes, like here the pneumonia, bacterial infection, fungal or viral, like now the COVID-19, so the viral infection, and or if it is aspiration, like the patient he vomit and aspirate again, if he's drawing, if there is any thoracic trauma, smoke inhalation, fat embolism, and the indirect like pancreatitis, severe shock, and motor organ failure. So what are the, if we are going down to the next slide regarding the ventilator strategies. So here the lung protective ventilator strategy is very important actually, because we have to give up the proper setting for the patient, because this is an artificial ventilation. So you need to give the patient what he needs from the ventilator. Like, for example, if you give the patient more tidal volume, more positive index respiratory pressure, you will cause more volutrauma, more pneumothorax or barotrauma. So it will be harmful. But if you give low tidal volume or low positive index respiratory pressure, you might cause more atelectasis, and it will be more deterioration of the lung. So we have to be in this safe zone. We should avoid volume trauma, and this is the distended alveoli, or to collapse alveoli, we have to avoid it. So this is an example in histopathology. So this is another, the CT for the, they did it in the big actually model with the body weight of 30, and see how is collapsing consolidation with aerobronchogram, which is going and low beep. It's not the ideal beep for that. But here, if you see, it's how it's now it's opening with increasing the beep. So it's more open now. So you will find the consolidation is less. But if you see here, there is now it's became more aerated. This is the black is from the air, so it's more aerated area because of this one. So almost we are better, at least in the safe zone. Now it is more beep also, so it's opening more and more, and here the aeration is better actually, but you see it's more, and here more blackish comparison to the previous. If you can see the previous one, here the aeration is good, acceptable, but here it's more, and this is more risk to be pneumothorax or barotrauma. So here we, if the patient he has ARDS, we have to what is called lung protective strategies. So as we mentioned, we have to avoid volume trauma or attic trauma. So there is another here trial. It's called ARMA trial, which it was published in New England Journal of Medicine. They are comparing the intervention group comparison to the control group. The intervention group, the tidal volume, they calculated 4 to 6 ml per kg. So the here ideal body weight, it's different than the actual body weight. So it's totally different. So you have to measure one by one. Forget the actual weight. Here the ideal body weight. And what they found, like this patient, the body is obese. You will not giving according to his body weight. You will give according to the height. There is equation. You will calculate the ideal body weight, because the lung, it will be the same. It will not affected by the body size. It will be affected by the length of the patient. So here, this is the equation how we calculate it, because it's different from male to female. So again, if you go to the lung protective strategies, and what is your target? Here, the target, the idea should be the tidal volume, 6 ml per kg, and the plateau pressure, it should be below 30, and the PEEP according to the protocol, or there is advanced method now to calculate the ideal PEEP. So even the result here, what they found, it's actually the mortality is less with lung protective strategies compared to the conventional who receive higher tidal volume. So this is the protocol actually. It's available with RT, actually, the respiratory therapists. They are calculating and following this protocol. So here, ERDS net low tidal volume trial, they found the mortality is less than 28 days mortality. So please keep the tidal volume 6 ml or below to get better outcome. So here, this is a screenshot from the mechanical ventilator. This is the mode. You can see here the pressure control mode. Here, this is the peak which is the maximum pressure is achieving during inspiration. And here the expiratory minute ventilation. And here also how much the tidal volume it's ongoing now. Here you will see the plateau pressure, because this number is important, and here how much the tidal volume is ongoing. So if you see the setting here, the patient, we are giving the oxygenation. Here, the patient is desatting. He has low saturation. So what we need to improve the saturation. So there is a lot of methods we can use it. The patient is FiO2, he's in 50. Maybe you can increase the FiO2, it will improve the saturation, or you can increase the PEEP. So ideally, or the tidal volume, because how any area, can affect this area below the diagram, it will help to improve the oxygenation. Either this is the PEEP, the setting PEEP. So during the expiration, you will find this line. It's called the PEEP, which is 8. And here the inspiration, it will be the plateau pressure. And again, back to the PEEP. So if you want to improve the oxygenation, either we can increase the PEEP, increase the respiratory rate, or increase the tidal volume. But keep in your mind, we have to keep the plateau pressure below 30. So this is after adjustment. If you can see here, the minute ventilation, it was 4.3. But if you go here, you will find 6.7. What we did here, we increased the respiratory rate, PEEP it was increased, and even the plateau pressure, because once you increase the plateau pressure, the PEEP, you will increase the plateau pressure. Immediately it will be increased together. So improving the oxygenation, you need to increase the PEEP, or increase the tidal volume, or increase the FiO2. And respiratory rate also, it will help. But if the patient has CO2 problem, as it's common actually in ERDS, so what we have to look, like a patient has hypercapnia, so we need to look again for his the tidal volume to calculate it. how much he's taking, how many ml per kg, and look to the plateau pressure. Because if the plateau pressure is high, you could not play a lot, because our target below the 30, and it's the best should be 27 and below. It's better. So the plateau pressure, it's your aim. Once you increase the tidal volume, because here this is presenting the tidal volume. If you give more tidal volume, it will be more plateau pressure. And if you give more beep, it will be increase also the plateau pressure. So if you want to improve the CO2, you have to be careful about the tidal volume, how it will be. So again, how we can wash out the CO2? We can wash out the CO2 by increasing respiratory rate. This is very important. Or we can increase the tidal volume if the plateau pressure is allowing and there is no contraindication, like the patient has barotrauma, pneumothorax, so you have to be conservative. So to reduce the respiratory rate, to reduce, sorry, the CO2, you need to increase the RR, respiratory rate, or you need to increase the tidal volume if plateau pressure is allowing you. So the cost should be paid actually, usually the permissive hypercapnia. If the pH above 7.2, it will be okay. So in PEEP in ARDS actually, so this is the difference. As you seen, as you saw just now in the another slides, the CT. So here, if the beep is not the ideal, you will get more at like here the beep is 0. You will see there is more atelectasis, and the over inflated is less. But if you give more higher beep, like for example 15, you will find the alveoli is normal more, but also increasing the over infiltration, but less atelectasis. And when the beep is high, so it will be more over inflated. So this is just an idea for that. So does high beep improve the outcome in acute lung injury? So depends. So just we go for this question. This patient, he's in control mandatory ventilation, volume control actually. He's in FiO 200%, beep of 12, and tidal volume is 420. Respiratory rate is 20, plateau pressure is high, 32, and ABG 7.18 because of CO2 retainer. And saturation is still desatting. So what is the next? How we can improve his oxygenation and improve the CO2? You can write in the chat room, please. So prone position. Any other thought? So because here, if we can calculate the PF ratio, because the prone position and muscle relaxant is indicated if the PF ratio below 150. So here already the saturation, the BO2 is 55. If you will calculate it, it will be 55 the PF ratio. So it's the prone is indicated. How we can other after prone, what we can do? So here muscle relaxant we need to add. The prone also here we need to add. Here the plateau pressure is high, so we could not play with the tidal volume. May we can increase the respiratory rate also. It will help at the same time. So actually we need to increase the respiratory rate, and after that also the prone positioning. But PF ratio less than 150 is an indication for proning. So this is an example for prone, but it should be the prone in the trained people with someone expert with the nurses, because any mistake it can be dislodge and extubation. It will be very harmful and can cause arrest also. So here, when to consider rescue therapy for refractory hypoxemia. So what are the refractory hypoxemia actually? Because here there is no official definition what's the refractory hypoxemia, but some they are saying it is below 50 the PO2, or if I2 more than 70. persistence, the time more than 24 hours. Some they are saying this is a PBT. You can increase, you can do the lung recruitment with PBT up to 25, or just you have to ruling out all the reversible causes. So here, this is a slide. If the patient you have severe hypoxemia, and because of ERDs we are talking here, we will go to the protective lung strategies. So what's our target here? The tidal volume should be 6 or less, but we have to keep the plateau pressure below 30. If it is no, still we didn't achieve the target, again, we have to go. If the tidal volume, for example, it's more than 7, we will titrate it more than 6, I mean, you will go down with the tidal volume until the plateau pressure is low. As we mentioned, when you decrease the tidal volume, the plateau pressure will be less. And if you increase the tidal volume, you will increase the plateau pressure, because we need to keep the plateau pressure 30 or below to protect the intact lungs and to avoid more harm. But if it is already within the target, just to check the cardiovascular assessment. Maybe he has heart failure, he need more diuretics and control. But so left heart failure, you will assess, and arterial pressure. If there is yes, there is heart failure, you will give diuretics and reassess again. If no heart failure, no evidence of that, so you will check another, maybe the patient hypovolemic, maybe hypotension. So you look for another causes. If yes, the patient already hypovolemic or hypotension or low venous oxygenation, so you might consider fluid resuscitation or vasoactive medication. So if it's still also again hypoxemia, or there is no any finding of that, you will go for more assessment for the right heart failure, because it can be common with the ARDS developed because of high beep, hypoxemia. It can cause RV failure, acute RV failure, and also it can cause sometimes maybe some patient they developed pulmonary hypertension and pulmonary intracardiac shunt, so need further assessment by echo. So just keep in your mind, hypoxemia doesn't mean just only the patient he needs to increase FI2, increase the tidal volume. So you have to keep in your mind what is the issue with hypoxemia, because sometimes hypoxemia, the patient is okay, suddenly he has hypoxemia, maybe the tube is kinked itself, the filter is blocked, so you have to reassess. Maybe there is large secretion, you have to clean suction, closed suction it will be. Sometimes also the problem with hypoxemia, the patient is become anuric, acute kidney injury, volume overload, you have the diuresis, or he developed acute coronary syndrome, acute heart failure, so you need to diuresis. As we mentioned in the previous lecture regarding the shocks, you have to reassess the patient frequently. Here the same, you have to assess the patient frequently with the volume status. So again, if you go to the heart failure, you go for the echo assessment, because if there is nothing any explaining any cause of that, so only the ARDS in front of you. So as we mentioned just now, if the BF ratio below 150 is an indication to go for muscle relaxant, and also you can go for proning. So take care of your back, because of you may need it in one day. So here just an example for a prone position. This is the supine, this is the prone position. Here the CT during the prone, sorry, in the supine position. See how is the consolidation here, which is filled with, because the pneumonia is filled with the pus. But after you turn the patient, here the infected area or the consolidation, it will be up. So it will make a drainage for this alveoli to go, the secretion from the alveoli to go down. So it will improve this alveoli to give the time to recover also. So here there is another trial called ProSiva. This is done in 466 patients. with severe ERDs, the prone position versus supine position. They found, in this trial, actually, they found there is improving mortality in 28 days and 90 days. But overall, the complication, there is no complications. But this is, should be in the trained staff, because if they don't have trained staff, they might lose the patient. So here, this is another scenario: patient with FiO2 70%, beep of 14, RR is 22, plateau is 32. Here the pH actually 7.29 and BO2 85, BCO2 49 improving, and SpO2 improving 94. So what is the next? This is the same patient, we put him in the prone position. So keep the patient in the prone for another 16 hours. Or put the patient in supine for 8 hours and then prone him again. Or prepare him for ECMO. So you found that initially he was Fi 200 and PO2 it was in 55. So now he is improving actually. If you calculate the PF ratio, the PO2 is 85 divided by 70, you will find the PF ratio is 122. So already significant improving. So you keep the patient in supine position, then again another prone, and he's respond for the prone position. So in conclusion, so the prone is improving actually the oxygenation in 2/3 of patients, because sometimes some patients they are not improving. So there is no improvement in survival. They are saying decreasing mortality, but it doesn't improve the survival or the time of ventilation or the time in ICU also, but might be used in refractory hypoxemia, which is the PF ratio below 150. And the optimal time or duration for that, it's controversial, because some recommendation like sepsis campaign, they are saying you can use it 12 hours. Some they are saying 16 hours. So routine use is not recommended. So if the patient he has hypoxemia after prone position, you rule out other causes for that, like cardiac causes or shunting or reversible causes. So you have to go to the sulfage therapy, which is called the ECMO, extracorporeal membrane oxygenation, VV ECMO, venous ECMO. So because it will help for oxygenation and also for the CO2 retainer, and give the time for recurrent. So if we have refractory hypoxemia, we can go for prone position, inhaled nitrous oxide, maybe H4 now it's off label, and going for ECMO. ABRV maybe some they are using, but it's not common actually. It's rare to be used because you need to be spontaneously breathing. So the ECMO will be here, the recommended one if still refractory hypoxemia. So in the COVID, there is special called key facts. Actually, you have to keep it in consideration. You have to keep it in your mind, because some patients actually they have good lung alveoli initially, which is called low resistance, because they don't have that much resistance. But later on, they can develop high resistance. So you have to follow the patient, the compliance of the lung properly, because better compliance, better lung, less need for high beep. But if the patient has low compliance, mean there is more resistance, this is mean you need higher beep. Avoid, keep in your mind, avoid the fluid under or over loading, because the balance should be EU balance. Avoid hypovolemia, avoid volume overload, because it will make you in trouble for his oxygenation. Consider permissive hypoxemia, because saturation may be 88, so it's acceptable for them. Although now there is another trial they are just published, who has saturation 94 and above, is better outcome than permissive hypoxemia. So accepting and also for COPD, it should be you can accept lower. So also proning is very important and very successful for them.
Excuse me, time. You are exceeding 5 minutes.
Okay, خلاص. Almost we are
Thank you.
finished.
Okay, thank you.
So there is so this is the most important actually, just for the time. And here, just if the patient has hypoxemia, we can start with if the patient is walk of breath, allowing us not abdominal breathing, you can start initially nasal cannula. If not responding and he's severely desatic, you can go either high flow nasal cannula or CPAP, especially the helmet, because it's decreasing the need for intubation. If they failed for that or they are not fit, or there is a contraindication like low GCS, they could not maintain the airway, you will go for invasive mechanical ventilation. If the BF ratio, as we mentioned, below 150, you will go for proning position in addition to that muscle relaxant. If failed, you will go for VV ECMO. And thank you so much. If you have any question, please, you can write in the chat room. Is there any question? Okay, thank you so much. Tomorrow it will be the last day. It will be, there is actually 3 lectures will be, and after that it will be the exam. It will be, after we finish, we will send the link in the group and here in the Zoom also. It will be the answer 40 question over 40 minutes. The pass rate, it will be 50%. You have to pass in the exam. Please, all who has any problems at that time, because it will be 40 minutes. If you have any duties or something, inform us earlier to arrange the exam for you later, because we cannot accommodate a lot of people. They are just, they didn't attend then again another exam. It will be fixed time. So please, all of you to attend in the proper time to do the exam also. And after the exam, if you pass the exam, you will get the certificate through after the check your attendance also. Thank you so much, and see you tomorrow, inshallah.